Welcome to today's webinar, Complex Spinal Injury Rehabilitation and Recovery, Interdisciplinary Strategies to Maximize Function and Return to Work. This webinar is hosted by Medical and Life Care Consulting Services, case management and nurse consulting firm headquartered in Massachusetts, in collaboration with Dr. Jerrold Kaplan of 𝐒𝐻𝐢𝐧𝐚𝐥 Specialty Healthcare. We're excited that you've joined us for this presentation. My name is 𝐒𝐩𝐢𝐧𝐚𝐥, and I'm the moderator for today's webinar. This webinar is anticipated to run about 50 minutes, with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link to where you can access an on-demand replay, along with a link to a short survey. Again, we're excited to host today's webinar and look forward to an opportunity to partner with you. To kick it off, I'll pass it to our host, Cynthia Bourbeau. Cynthia Bourbeau is president and founder of Medical and Life Care Consulting Services, referred to often as MLCC, and has worked as a Massachusetts registered nurse, certified rehabilitation nurse, certified nurse case manager, and certified nurse life care planner for over 3 decades. Cindy?
Thank you, Gigi. Now, before I hand this over, I'd like to share a little bit about the Injury Insight program. So Injury Insight is a 4-part webinar series designed to educate claims professionals, HR professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments, both common and uncommon, within workers' compensation. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, and potential obstacles, and answer your toughest of questions. So get your questions ready. For this session, the third this year, Complex Spinal Injury Rehabilitation and Recovery, and Interdisciplinary Strategies to Maximize Function and Return to Work, we're pleased to have Dr. Jerrold Kaplan of 𝐒𝐻𝐢𝐧𝐚𝐥 Specialty Healthcare share information on the different levels of post-acute care for spinal cord injuries, as well as advanced outpatient programs that facilitate return to work, including work conditioning and work hardening. Dr. Kaplan will also discuss the epidemiology and pathophysiology of spinal cord injuries, including the neurological levels of injuries, complications, and comorbidities that can impact recovery, as well as adaptive technology used for spinal cord injuries. Dr. Kaplan has been practicing for over 25 years as a board-certified physician in the field of physical medicine and rehabilitation. He previously served as Vice President and Medical Director at Gaylord Hospital in Wallingford, Connecticut, and is now back at Gaylord as Medical Director of Outpatient and Workers' Compensation. Dr. Kaplan specializes in treating complex neurological and musculoskeletal injuries and illnesses. He oversees Gaylord's COVID recovery and concussion programs, in addition to his role in treating a variety of work injuries. He is a former resident and chief resident in physical medicine and rehabilitation at Columbia Presbyterian in New York. Dr. Kaplan also serves on the Connecticut Workers' Compensation Medical Advisory Board. I am very thankful to Dr. Kaplan for doing this for us today. This is a topic that's near and dear to my heart. I have a lot of patients, and we have treated at Gaylord and have been really so happy with all the care they've given to our patients, and so I wanted to share all this with you. So take it away, Dr. Kaplan.
Thank you very much. Hopefully everybody can hear me and see the slides okay. If not, I'm sure Gigi will give me a flash that we're having some issues with that. So thank you all for participating in this webinar. It's great to be able to share a lot of information with this the diverse group. So let's start off talking about how often do spinal injuries occur. And it's estimated that about 18,000 new injuries occur each year, and about 300,000 people actually are living with spinal cord injuries in the United States. With the advances in some of the auto safety features, hopefully that number will continue to decrease in the future. but not all spinal cord injuries are related to motor vehicle accidents. So let me go over a little diagram in terms of where injuries are occurring. As you can see, the largest group is vehicular accidents, about 40% or so. 30% related to falls, then we get violence, sports, various medical, surgical, and other conditions. The average person with a spinal cord injury is in the mid-40s, and about 78% are men. In terms of levels, I'll be using the term quadriplegia. Tetraplegia is another word. It means the same thing. So all four extremities are affected, and the injury either can be complete or an incomplete injury with some sparing either of motor or sensory function. Later in the talk, I'll get into the specifics in terms of classifying various types of spinal cord injuries, but the big picture is roughly half of the injuries that we see are incomplete quadriplegia. About 20% are incomplete paraplegia, and then the rest are complete either paraplegia or the smallest number is complete quadriplegia. Once again, it's also called tetraplegia. I'm not going to spend a lot of time on anatomy because we only have about 50 minutes for material to be presented, and I have a lot of ground to cover, but I wanted you to have reference material, so when you go back and if you have a question about anatomy, just a quick general overview. The spinal cord is transferring the motor information from the brain down to the body, and then it transfers sensory information from the body back up to the brain. So if there's damage to that connection from the brain to the body, you can have motor, sensory loss, and other functions affected. The body is structured so that we have some protection to the spinal cord with our vertebrae. So usually when you have a severe spinal cord injury, you're also getting fractures of your vertebrae. So in order to get enough force to go into damaging the spinal cord, you're also having fractures. There's a lot of blood supply to the spinal cord, both anteriorly and posteriorly, and we have to worry about when we have major spinal trauma, arterial trauma as well. Sometimes there can be a laceration of the abdominal aorta, and obviously that can be a life-threatening type of injury. We see that with some of the most severe motor vehicle accidents. To get back in terms of some of the specifics, the most common injuries are in the cervical spine, and most of those injuries are at this level, the C3 through C5 levels. So this is where the vast majority of your spinal cord injuries are occurring. The most common level itself is at the C5 level, followed by C4 and then C6. So this region here is going to have most of your traumatic spinal cord injuries. We also see a number at the lowest portion of the thoracic spine, the T12 level, and then in the middle portion around T7. In terms of trying to classify a spinal cord injury, the American Spinal Injury Association has come up with guidelines called the 𝐒𝐻 guidelines. This is very important in terms of determining prognosis for patients. It also helps with various research. Gaylord is one of 14 model spinal cord injury centers across the country. So we've been compiling spinal cord data for decades, and this information is used to be shared for research and other factors throughout the country. So I'll show you in a second the actual form that's used. There are whole seminars, several days long, in terms of how to do 𝐒𝐻 scoring. So it's complicated with that. For the purposes of today's webinar, I just wanted to give you a general overview and to give you some reference information. So there are 10 key muscle groups, and you're always using both sides, and then there are key sensory groups. So let's get into a little bit more specifics. First of all, in terms of the scale, we have an A, B, C, D, and E impairment scale. This is a score where you do not want to get an A. The A is actually the most severe spinal cord injury, a complete spinal cord injury. The reason that they have an E is because some people recover by the time you're doing an 𝐒𝐻𝐢𝐬𝐳 scale and come back to normal motor and sensory function. And I'll get into some of the statistics in terms of how that's affected. So basically, A, complete, no motor, no sensory, no sacral sparing. So this is a person who has a complete transection of the spinal cord, a complete injury. B is incomplete. You have no motor function, but you do have sensory function. C is an incomplete, where half of the muscles have less than a grade 3. When we grade muscles, it's a 0 to 5 scale. 5 being completely normal, 0 being no muscle function at all. 3, which is the grade that we're talking about here, is with gravity being able to overcome that. So when you talk about less than a grade 3, you can't raise your arms and legs off the bed. D is a level where you have 50% of the muscles are more than grade 3. So those people can raise their arms and legs off the bed. And then, as I said, the E is the normal level. So this is the complicated scorecard that we actually use. On the left-hand side, you see the motor functions. And once again, as I said, this can be a several-day course on how to do this. But just to give you a general overview, the C5 are your elbow flexors. C6 are your wrist extensors. C7, your elbow extensors. C8, your finger flexors. And if you really want to get specific, you're going to use the distal end of your middle finger. And then T1 is your little finger abductor, meaning it going out to the side. So those are your motor scores, and those have implications for future function as well in terms of how independent the person is going to be. So you're going to do each of those muscle groups and you're going to score them. And then you're going to do a similar function with the lower portion of the body. The L2 are your hip flexors. L3, your knee extensors. L4, your ankle dorsiflexion, which means bringing the foot up. L5, your toe extension. And S1, your ankle plantar flexion, or bringing your foot down. And then you're going to look at the score of all of these different muscle groups and come up with a total score. You're going to do the same thing with the sensory function, looking at the various levels. And this chart is very handy. It shows you the different spinal levels. And you're going to score that either 0, meaning that there's no sensation at all, 1, that it's impaired, so they have some sensation, but it's not normal sensation, 2, that it's normal, or sometimes for whatever reason, you're not able to test that area. If you are an adjuster or a nurse case manager out there, it takes a long time to do this 𝐒𝐻𝐢𝐳 scoring, and really a person who has specifically trained in spinal cord injuries should do this 𝐒𝐻𝐢𝐳 score. So don't expect to get this 𝐒𝐻𝐢𝐳 type of score on your regular follow-up visits for your patients. It's usually only done at a few points in time in terms of the person's recovery. So let's talk a little bit about prognosis and recovery now. Once again, remember, A is complete, E is normal. So the 𝐒𝐻𝐢𝐳 level, those are those complete spinal cord injuries. So the cord itself has been severely damaged. The person has a complete spinal cord injury. About 20% will have some improvement in anywhere from a level B to a level E, completely normal. 10% of those will go to a C or a D, which is almost complete recovery, but not quite normal. Very few of them actually get to that E level, which is the normal level. But the good news, and this is important to tell patients when they come in, about 70% are going to recover to 1 level. So an 𝐒𝐻𝐢𝐳 complete, about 70% of those people will progress to an 𝐒𝐻𝐢𝐳 level. About 30% will actually get 2 levels. And remember, the more levels you gain, the more function you've gained. Once again, the initial presentation is a predictor for full recovery in the future. So obviously, someone who's a C4 complete 𝐒𝐩𝐢𝐻𝐸 spinal cord injury is going to have a poorer prognosis than someone who has an incomplete, say, C6 𝐭𝐸𝐲-C score, for example. Most of the recovery does occur within the first 6 months. In the old days, we used to say if someone hasn't recovered by 6 months to a year, they're probably not going to recover at all. That's not really true now. We are seeing neuroregeneration. There's a lot of research going on right now in terms of various techniques that can be done to try to help people recover from spinal cord injury. Everything from trying to do surgical procedures to reconnect the spinal cord, to stem cells, to electrical implants. So a lot of work is being done. Unfortunately, we're not at the level today where we can tell patients who have a more severe spinal cord injury that they will be able to gain function. But there is a lot of research going on with that. For those individuals who have incomplete injuries, such as an 𝐒𝐻𝐸 B or C, you can see the statistics. And I'm not going to go through each of these levels. This is more for a reference for you to have in the future. Getting into more of the pathophysiology, that is, once again, more for a reference for you to have. Central cord syndromes, those are the patients who have upper extremity more involved than lower extremity. So these are what we call the walking spinal cord injury patients. The lesion has occurred in this area of the spine, in the central cord. It's affecting the upper extremities more than lower extremities, so they can have a lot of weakness in their upper body, but actually be able to ambulate. The Brown-Séquard syndrome with this cord hemisection. These are the individuals who have ipsilateral, meaning the same side, loss of motor function, and proprioception. That's your position in space, so you can tell like where your feet are when you're walking. It impacts balance, coordination activities with your hand. And then they have contralateral, or opposite side of the body, loss of pain and temperature sensation. The anterior cord syndrome has a loss of pain and temperature below the lesion. Posterior cord is a very rare condition. That's loss of fine touch, vibration, and proprioception. Then we get into some of the more common syndromes that we see, things like cauda equina syndrome, which is in the lower portion of the spine. This is your cauda equina down here in your lumbar area. Those are the lumbosacral roots. It's a motor neuron, lower motor neuron involvement with that. You see bowel and bladder difficulties. You can have some issues associated with neurological function and strength in the lower legs. And then you get into some specific root level conditions from compression and other trauma to your lumbosacral roots themselves. Primarily the sacral cord is involved with conus medullaris. Okay, now that we have a little bit of a background in terms of the levels of spinal injury and the types of condition that we see, let's talk about the actual accident itself. So you're an adjuster, a nurse case manager. You've been informed of someone that's had a work-related motor vehicle accident and now has a traumatic spinal cord injury. So what's going to happen to that individual? At the scene, they're going to have emergency services. You're going to try to stabilize the spine. I'm also a scout leader, so I teach first aid to my Boy Scouts. And this is critically important. When you're at the scene, you want to prevent further injury so that you want to make sure that you're stabilizing the neck. Remember a few minutes ago, we talked about the most common spinal cord injuries are actually in that C4, C5, and C6 level of the spinal cord. What you want to do is stabilize the neck so you don't make an incomplete injury into a complete injury. So there are various types of devices that we use for cervical spinal stabilization that the fire departments have, emergency rescuers have, that you see at various pools and other locations, really designed to stabilize the spine to prevent trauma to the neck to change an incomplete to a complete injury. There are various protocols in place for using high-dose steroids in the emergency room to decrease swelling in the spine. to prevent further progression of spinal cord injuries. When we do a trauma workup for someone who's had a major traumatic spinal cord injury, you want to look at the entire spine. They may be focused more on the neck, but that doesn't mean that they also didn't have fractures in their lumbar spine or their legs or their arms. Unfortunately, in the old days when I first started at Gaylord about 30 years ago, we used to get major spinal trauma patients that came in, and everybody would be focusing on their neck and their spinal cord injury, and they'd miss the fact that they had a brachial plexus injury in their arm and had lost further arm function because of nerve damage to the brachial plexus in the arm, or they had a non-displaced fracture of the leg. So our emergency trauma workup is much better now, but you really want to make sure you survey the entire spine, do a survey to make sure there's no other body parts affected. Many spinal cord injuries also have traumatic brain injuries. That's a whole other lecture in terms of traumatic brain injuries, but many patients have dual diagnoses for traumatic spinal cord injuries as well as traumatic brain injuries. So it's critically important to do a neurological examination of the motor, sensory function, bowel and bladder function, their cognitive status, their respiratory status, a real thorough evaluation of all of the aspects that could be affected from a major accident. Because of the risk of converting an incomplete spinal cord injury to a complete spinal cord injury, about half the patients wind up undergoing spine stabilization surgeries. And that's to protect the cord. There are various ways to do that spinal surgery. There are various types of collars that people wear, everything from hardware with halos to Miami collars to J collars, etc. In terms of surveying the spinal cord, the MRI will show the neurological detail much better than a CT. So you're looking at the MRI for swelling of the spinal cord, bleeding, ligamentous damage, disc herniations, trauma to the cord itself. The CAT scan is better for bony trauma to make sure that there's no fractures of the vertebrae, the pedicles, any other aspect of the spine. Just as a side note, we do see, unfortunately, workplace violence. So gunshot wounds do occur in work-related injuries. For gunshot wounds, depending upon the location of the bullet, it actually can be more hazardous to the patient to remove the bullet than to just leave it in place. So many times with gunshot wounds, if there's a bullet that's close to the spine, they actually will leave the bullet alone and not take the bullet out. That varies, obviously, depending on the specific circumstances, but that's something you have to be very careful of before you do a bullet extraction in a work-related violence that has a gunshot wound and subsequent spinal cord injury. So the individual went from the scene of the major traumatic accident. They've gone to the acute care hospital. Now you're an adjuster, a nurse case manager, and your patient, your client that you're working with is ready for the next level of care. So how do you choose where they go? From acute care, they have several different options. One option is in what's called a long-term acute care hospital, and that's actually where I practice. Gaylord Hospital is a long-term acute care hospital. So it's still a hospital level of care, but it's for more complex patients that are going to require longer hospital stays. So at an LTAC like Gaylord, we can take medically complex patients. So that means the patient can come straight to an LTAC right out of the ICU. They can come on a ventilator, be ventilator dependent, have major orthopedic trauma. There are intensivists, hospitalists. I'm a physiatrist, physical medicine and rehab. We have physiatrists, pulmonary, GI, the whole cadre of specialists. So an individual can deal with their medical problems as well as all of their rehabilitation needs. There's 24/7 in-house medical coverage. So there's not someone that's just on call by a beeper. They're actually in-house. And that individual is going to stay on average for 25 days. Obviously, the more severe injuries, the longer length of stay. The difference between an LTAC level of care and an IRF or inpatient rehab facility is really that medically complex level. Most IRFs have to take patients who are medically stable. So you can't take a patient directly out of the ICU. They would need to usually be on a medical or a surgical floor first. They require them to be able to participate in 3 hours or more of therapy per day. The difference between an IRF therapy level and an LTAC therapy level is there's not a specific therapy requirement. In an LTAC, you may have a very medically complex patient, ventilator dependent, ICU level patient, who maybe can only tolerate an hour or an hour and a half of therapy per day. Or you can have someone towards the end of their LTAC stay who might need 4 or 5 hours of therapy per day. So there's no specific rules in an LTAC for the amount of therapy. But in an IRF, they have to be able to tolerate at least 3 hours per day. They're usually covered by a physical medicine and rehab physician. Oftentimes, there's no intensivist, there's no internist. They just have those individuals available on consult. So they would have to wait potentially a couple of days to have someone come in. And to be certified as an IRF facility, they have to meet the criteria that 60% of their census has to be in 13 specific diagnoses. And usually the length of stay is 2 weeks or less. So a different population. And then we have the SNFs. These are for patients who are in the acute care, who might have a lower level of rehabilitation needs, or they might just have an injury that has wound care that's going to require a longer hospital stay, and then they're ready just for a SNF level. They're otherwise medically stable. A SNF patient doesn't require that medical oversight. Some of the SNFs have weekly visits. Some don't see the doctor except for once a month. And then, of course, we get those patients who have had major multiple trauma but are medically stable and are actually ready to get discharged directly from acute care to an outpatient setting or a comprehensive outpatient spinal cord rehabilitation program combining PT, OT. If they have combined SCI, meaning spinal cord injury and brain injury, they may also need speech therapy. So those are your choices after acute care: LTAC, inpatient rehab, SNF, or outpatient. So let's talk about the rehabilitation model itself. The critical issue is a team approach. And there are different ways that you can have a team approach. The best approach is what we call an interdisciplinary team. So the team members are actually constantly talking to each other. That's different than a multidisciplinary where the person might be getting OT, PT, or speech, but everybody's operating in their own unique environment and there's not close communication. So the best outcome for the patient is rehabilitation that starts early, that's coordinated by nurse case managers, physicians, therapists, and everybody's talking to each other, addressing the medical needs, the physical needs, psychological needs, social needs. We include the family from day one. We try to educate about prognosis, medical issues, return to work issues, home care issues, etc., to improve their overall function and quality of life. Now they're in your facility, whether it's an LTAC or a rehab facility or potentially they've gone home. What are some of the things that we have to worry about after someone has had a spinal cord injury? And I'll go through these categories just so you're aware and can realize if there are issues that these problems need to be addressed. So starting with respiratory complications, this is the most important feature because it is the leading cause of death in spinal cord injuries is respiratory-wise with pneumonia as the most common cause of death, especially in higher spinal cord injury patients. Depending upon the level of injury, the diaphragm and other diaphragmatic muscles will be affected, which leads to a higher risk of pneumonia for that individual. At the C3 level, which is a relatively high level of a spinal cord injury, about 50% of the patients can be weaned off of a ventilator. Patients at a higher spinal cord level that are on a ventilator, we usually have them trached as opposed to just being intubated. With the trach device in place, you can do suctioning, you can change your airflow, not only the amount of oxygen, but the oxygen pressure. Our speech therapy department can put various phonation devices in place. Remember, if an individual can't use their arms and their legs and they can't talk, it's a huge functional impact to them. So we want to be able to do a phonation device as soon as possible. And as we look at spinal cord injury patients, we also have an increased risk of pulmonary problems and sleep apnea and sudden death at night from sleep apnea. So once again, this is meant more as a reference slide. I'm not going to go into a huge amount of detail. So the diaphragm is supplied by the C3, 4, 5 levels. So anything above C3, so the C2 level, you're going to be apneic. So that means you can't breathe at all. And then depending upon the level will impact how much respiratory function you have. So if you're a C3 and you only have partial diaphragm use, you're going to get a very weak vital capacity and inspiratory effort. C4, you have loss of some of the diaphragm. And then as we get to the lower levels, you get down into the issue in terms of your accessory muscles, your intercostal muscles, your ribs, your abdominal muscles. So even someone who has an intact cervical spine can still have respiratory problems because of the weak thoracic muscles supporting and helping the diaphragm. We also have risks of increased pneumonia because of a weakened cough, increased risks of aspiration, et cetera, associated with that. Skin complications are in about a quarter of the patients each year. Higher risk factor for skin complications are people who have anything that will damage the skin. So a lot of this is just common sense, urinary incontinence, if you're older and have thinner skin, if you have low blood counts, if you're anemic, low platelet counts, all can be associated with higher risk factors for skin complications. An interesting factor is paraplegics actually have more skin problems than quadriplegics, and that seems counterintuitive. Well, the issue is in quadriplegic patients where they can't move, everybody's focusing on skin all the time. With a paraplegic patient, if the patient is relatively functional and getting around and sitting in a wheelchair for most of the day, they're at increased risk for pressure ulcers while they're sitting all the time and trying to function at a wheelchair level. So we want to try to prevent that. We want to make sure they have good nutrition, turn them as appropriate. And then if they do start developing a wound ulcer, we want to treat it early on to prevent it going from a superficial ulcer to a deeper ulcer that can lead to complications such as sepsis. So we use a variety of specialty types of mattresses, depending upon the kind of spinal cord injury. We can adjust the mattress. There's different vendors. There's different types of boots and bed positionings that we can use. And then we actually have a whole wound care team at our institution that will consult on different types of antimicrobial skin cleaners to prevent wounds becoming infected, different types of barrier products, cleaning solutions, et cetera, with that. Once again, we want to prevent pressure on the area. We want to use various healing conditions. With that, you can get heel ulcers, you can get IT, ischial tuberosity ulcers, you can get sacral ulcers. Sometimes you can even get ulcers at the back of the head in the occipital region if the person doesn't have good sensation in that area as well. Moving on to spasticity. Spasticity is very common in spinal cord injury as well as brain injury patients, also seen in things like multiple sclerosis and other types of injuries. So spasticity, it can be painful, muscle stiffness, you have tightness of the muscles, it can cause joint deformities and really impact function and care. Sometimes it can be so severe that you can't even do toileting to a patient with that because you can't get their legs apart. It can cause breakdown. It can be very painful with that. Spasticity can sometimes be severe for a long time and lead to a contracture. The difference between spasticity and contracture is spasticity is a velocity-dependent tightening of the muscles versus when you have actually a contracture, it means the muscle is fixed in position. So whether you move the extremities slow or fast, you're not going to have any change in terms of the range of motion if there's a true contracture versus spasticity. In terms of treating the spasticity, we have a variety of oral medications that we use. Probably the two most common that we're using today are Baclofen and tizanidine. Those are the ones most commonly used on most spinal cord programs today, both inpatient and outpatient. Botulinum toxin or Botox is the most common, but there are about 6 different varieties of botulinum toxin on the market now. Botox is one of the first and is the most commonly known, but there are lots of different types of botulinum toxin available. We don't usually do much Botox on an inpatient, although we do in some cases. The Botox injections can be extremely effective, lasting anywhere from 3 to 6 months, although most patients get about 3 to 4 months in terms of release from the Botox. You can develop antibody formation to the botulinum toxin, so that's when you may want to move to a different type of botulinum toxin if you've actually built up antibodies to it. There can be some side effects with flu-like illness, generalized weakness, skin irritation, etc. with that. In more severe spasticity treatment, and by the time you get into considering intrathecal baclofen, you're really talking about someone who has progressed from inpatient care to outpatient care. This would be the individual who you've tried a maximum oral dose of the medications. They still have severe spasticity, maybe impacting their ability to ambulate if they have an incomplete spinal cord injury, or it may affect bowel and bladder function and self-care issues. You can do a test dose where you actually have the individual come in overnight to a facility and do a bolus dose of the baclofen, and then you're going to test them for their spasticity, function, and range of motion. That's been cut back a lot during COVID. A lot of facilities cut out their intrathecal baclofen test pump programs. But we have a lot of patients that we continue to follow in our outpatient clinics who have these implantable intrathecal baclofen pumps that need to get them refilled on a regular basis. And how long it lasts between the refill depends upon how much baclofen you're actually using. And the pumps all have alarms. You obviously don't want to wait till the end because they can get severe medical complications if someone has been used to having intrathecal baclofen and then the pump runs dry. Once again, pain management is a whole multi-hour talk itself. I have talks on managing pain the non-narcotic way, but just for this audience, just a general overview. There are different types of pain. Obviously, there's the acute pain from the spinal trauma itself, and that would be the condition that you may be using some of the stronger opioid-type pain medications in the acute care hospital if someone has had major spinal trauma with fractures. Then you get into the subacute condition, and various people define that a different way. Chronic is defined in some places at 6 months or more of pain. Some will define it as 3 months. Usually we talk about acute being within that first 1 to 3 months, subacute being 3 to 6, and chronic being 6 months or longer. Some people would have the definition acute is only up to the first month, subacute 1 to 3 months, and chronic 3 months or longer. And there are various types of pain, and we choose medications depending upon the type of pain. So central pain coming from the central nervous system itself is more diffuse. Then we have radicular pain. If a particular nerve is affected, that's often sharp, burning type of pain that goes down the arms or the legs. We have visceral or organ pain, and then we have neuropathic pain that can be burning, tingling, buzzing type of pain. And there are different medications to use for different types of pains. So if someone has had a spinal cord injury and they have more arthritic or joint type of pain, that may be the case that we're using more of a joint-related anti-inflammatory type treatment. If it's more neuropathic type pain, we may be using neuropathic medications, things like gabapentin, pregabalin, some of the low-dose antidepressant medications, anticonvulsants, etc. Once again, pain is a complication that we worry about, but a whole separate lecture itself. We do want to try to avoid opioids when at all possible and not get someone hooked on opioids because then it's very hard to get them off of it. Just to briefly review bowel and bladder management, remember the spinal cord injuries, the bladder can be affected and cause either a complete loss of bladder function where someone has to have intermittent catheterization, or the bladder can be affected in terms of the muscles of the bladder with that. We try to take Foley catheters out as soon as possible. Ideally, we don't want any of our patients to have a Foley catheter in place. There may be some extenuating circumstances that a Foley might need to stay in, but the vast majority of the patients, the Foley should be taken out. It's a seed for infections and problems with that. It's important to have a good intermittent catheterization program that is coordinated by your nurses, doctors, APRNs, physician assistants, all the therapists. If someone does not have an appropriate intermittent catheterization program and they have a neurogenic bladder, then they're at risk for the bladder getting dilated and leading to severe complications such as autonomic dysreflexia that can develop from the catheters being kinked or bladder irritation, infections, etc. with that. Similarly, with the bowel, chronic constipation is a real problem that can lead to bowel obstructions and medical emergencies with that. You have both voluntary and autonomic control, and depending upon the level of the spinal cord injury, it can impact bowel function. It's critically important to have the patient on an appropriate bowel program. Usually that's a combination of something to soften the stool with a laxative component to it. There are also various manual stimulation devices that can be used. Hydration is key. If someone does not have the appropriate level of fluids, then the constipation is going to get worse. And some of the agents used to treat chronic constipation are worse if someone doesn't have enough fluid. And these are just some of the devices that we use. I'm going to go through some of these next slides relatively quickly so that you can see some of the advanced rehabilitation devices. Once again, these are for your reference, different types of devices that we use for bowel and bladder management, cathing devices, mirrors, knee spreaders, etc. I bring a few slides related to sexuality and intimacy. It's critically important in spinal cord injury patients of all ages. It's not just spinal cord injury patients for younger patients. In order to have a normal, healthy life, you have to address all of the issues associated with spinal cord injuries, bowel and bladder functions, sexual functions. So a good rehabilitation program needs to include a team that's going to address sexual function as well and not be afraid to talk about sexuality. There are various medications that can be used. Obviously, bowel and bladder incontinence issues can affect sexual function. Positioning can affect sexual function, various types of trauma. So we work with our social workers or psychologists. So sexuality should be considered even in a work-related injury in order to help with quality of life for the individual and help prevent anxiety, depression, and other complications that can develop as a secondary factor for spinal cord injuries. Deep vein thromboses, once again, this is a whole talk. Spinal cord injury patients are at higher risk for deep vein thromboses, both paraplegic and quadriplegic patients. We have various medications that we use for prophylaxis of deep vein thromboses. We also try to get someone mobile as soon as possible for that and use various functional electrical stimulation devices to help circulation as well. Deep vein thrombosis can lead to pulmonary embolisms, which can obviously be life-threatening. And once again, we try to diagnose it. The Wells criteria look at things like level of spinal cord injury, previous history of cancer, tenderness, swelling, etc. And the diagnostic Doppler ultrasounds are usually the venography gold standard with that. HO, or heterotopic ossification, is bone that forms in an area where it shouldn't be. This can cause pain, loss of function. We commonly see it after spinal cord injuries as well as traumatic brain injuries and burns. You have an elevation in alkaline phosphatase, but this, you can imagine, will prevent function. You can't bend the knee if you have bony calcium that has formed in the wrong place. And we treat that with early range of motion, non-steroidals, surgery once it matures. If it's immature and you try to do surgery, it's like trimming a rose bush. The bones will grow back right away. Radiation to treat it was used for a while. It's controversial now. It sometimes is used for prophylaxis in hip replacement surgeries, but not usually in spinal cord injury cases. Now let's get into some of the rehabilitation, and this is my favorite part and the fun part of the talk. Everything from water therapy to sports, etc. is key. And I'm going to just spend a few minutes on talking about some of our advanced adaptive devices that we have. We want to work with the patient on range of motion, strengthening, sports activities, recreational activities. I work with a lot of individuals who are police, firefighters, EMTs, construction workers. They've always been very physical in their life, so it's important to bring that back into them, and that will also help them gain function and motor strength to get back to work as well. In terms of adaptive equipment, depending upon the level, we have everything from mouth devices to various hand devices, different stylus, voice-activated devices for computers. So spinal cord technology is a whole field in itself, and you really need to work with an institution that has expertise in these adaptive type of equipment. We have a certified physical therapist who's nationally recognized in wheelchair design, whether they need a manual wheelchair or power wheelchair. Pressure is very important to make sure that you have the proper seating for your power wheelchair. So that needs to be looked at very, very carefully. And then we have various devices that can get people up and about quickly. So I'm going to go through a few of those. The earlier you mobilize patients, the less risk of complications for things like deep vein thrombosis and pulmonary embolism, and it also helps psychologically with patients. There are various devices that we can use if someone has had a spinal cord injury and has partial weight bearing. In the old days, you used to say, okay, 20% or 10% weight bearing. You really couldn't tell how to do that. Now we can. I talked about functional electrical stimulation in terms of deep vein thromboses. We have functional electrical stimulation with bikes. We also have gait. We can do either surface or implantable stimulation, phrenic or diaphragmatic stimulation. So functional electrical stimulation is a major factor for a good spinal cord injury rehabilitation program. And then we have various adaptive devices to allow spinal cord injury patients to walk. This is called the 𝐒𝐻𝐢𝐻𝐿 device. This is an individual who has a complete spinal cord injury but is able to ambulate. They can go to work. They can get around their house with this wearable robotic type of device. This is another brand, ReWalk. It's slightly different design. With that, the body is tilted forward a bit. It does repositioning. So we have patients work with their therapist on this as well. Then in our therapy gyms, we have various devices to eliminate gravity. This one's called the 𝐒𝐻𝐢𝐻𝐳 device. It's a sling type device, and you have it set up throughout your gym so the patient can actually walk throughout the gym. They can practice falling and getting up from the ground. They can practice going up and down stairs if they have an incomplete injury, and it's in a safe environment. You can track their project. There are various computer programs that we can look at. So we can get spinal cord injury patients up and about in an upright position like we never were able to do in the past. This device is called an anti-gravity or altered G. It was designed by NASA. You can do it anywhere from 20% of the body weight up to 100% of the body weight. It's more limited because it's on a treadmill type setting as opposed to the 𝐒𝐻𝐢𝐻𝐳, which you can walk around the gym and do steps. But you can do video monitoring of their gait pattern with this device as well. The 𝐒𝐻𝐬𝐧𝐞, this is one of my favorite devices. This is for balance. You have a screen. This is good for people who have weakness in their legs and balance problems. It's good for people who have combined brain injuries, spinal cord injuries. You can do everything from walking on uneven surfaces to being at the beach to being on a subway. You can take them anywhere you like on the video, and then you can record their objective progress in terms of their balance and their vestibular system. The BioNS Integrated Therapy System, or the BITS system. A lot of patients have spinal cord injuries and brain injuries. This is one way of looking at balance, coordination, visual, and motor function all together. This is the BITS balance, where we put a balance scale while they're doing visual exercises. And then just some adaptive technology. This is a ParaGolfer, so someone with a spinal cord injury can get up and play golf with that. We do a lot of work with aquatic therapy for our spinal cord patients. It allows them to gradually build up their strength in an environment with that. It's great for pain control. There are obviously issues of incontinence. They can't go into the pool if they're incontinent of bowel or bladder. And then we have a whole therapeutic recreation program, everything from archery to swimming to sports. We have called the Gaylord Gauntlet. It just helps build up their physical confidence and strength and ability as well. We have multiple sports that our patients can participate in. The last part of the talk, and I know we only have a few minutes left, is talking about work conditioning and work hardening. The difference between work conditioning and work hardening is often confusing to people. When we talk about work conditioning, we're really talking about physical functioning. So instead of just doing physical therapy 2 or 3 times per week for a half hour to an hour, you're doing several hours of therapy per day, usually 3 to 4 hours. Some people we actually do up to 6 hours, anywhere from 3 days a week up to 5 days per week. So if you've had someone like this individual, this is Eric, who was a firefighter who had a spinal cord injury, went through major multiple trauma, inpatient, outpatient rehab, and wanted to be able to get back to doing firefighting. Well, this uniform itself, with the oxygen, all the equipment, weighs about 70 pounds. So just because someone can do exercises in a gym doesn't mean they can get back to firefighting. So in a work conditioning program, you're building up their strength, their endurance, looking at their ability to deal with emergency situations, and then gradually building that up with the goal of getting them back to a full duty release for work. Work hardening is for those individuals who need the physical component, but they also need other things. In addition to just physical therapy, they might have needs for occupational therapy, for coordination, function, visual aspect. They might have needs for speech therapy. At Gaylord, we treated a lot of work-related COVID. So we had patients that had respiratory issues as well as physical issues. Sometimes they're nutrition or psychological issues. So this is really an interdisciplinary program that combines all of the physical activities with other aspects. The goal, once again, is to get someone back to work with the best medical care in the least time and the most cost-effective fashion. I mentioned pulmonary rehab. We've treated a lot of firefighters, EMTs, police officers who have had a combined respiratory as well as physical issue with conditions, say, as a work-related COVID or other conditions. Nutritional counseling can be key. If someone is morbidly obese, it didn't necessarily cause their spinal cord injury, but it can make it much worse in terms of trying to get them back to work. A weight loss program, obviously, if they have diabetes or other nutritional issues, that can affect wound healing and put them at risk for further urinary tract infections, etc., as they recover. Psychology is a huge component, whether it's dealing with their spinal cord injury, dealing with chronic pain and using a variety of imagery, biofeedback, and other psychological techniques. Sometimes we have to do neuropsychological testing if there are cognitive aspects that we're concerned about getting them back to work as well. So those aspects, if we put all those other pieces in place, that would be more of a work hardening type of program rather than just the work conditioning program. And once again, we want to give patients confidence. We have a lot more tools today than we ever did in the past in terms of getting patients back, the prognosis for recovery, using all of these different techniques, using medications, using therapy, using technology is much better than it ever was 10, 15, 20 years ago. If we tell them that they're never going to walk, that they're not going to ever get back to work, it's got a self-fulfilling prophecy. So we really want to give them a positive message early on because it is very possible, as I showed you early in the talk, that even complete spinal cord injuries can progress to incomplete and gain back function. And we need to be realistic at the same time. They're unlikely to go from a level A complete to a level E normal, but they might get to that B or C level and gain a lot of function. So overall, by a holistic program, an interdisciplinary team, empowering the individual, giving them education, giving them the tools, gives our spinal cord injury patients the best chance for the most complete recovery. I've listed a number of references for you for this talk, and it's not just humans that have spinal cord injuries. So just a little slide of a dog that has had a spinal cord injury, and you can see the adaptive technology associated with that. So I went a little bit over. I apologize for that, but we have time for a few questions if anyone has. I'll turn it over to our moderator, Gigi, now to share if there are any questions that people have.
Awesome. Thank you so much, Dr. Kaplan. That was a wealth of information. I love our doggy here who also has had an injury and adaptive technology. This is amazing. So at this time, we will shift into our Q&A session. Please be sure to submit your questions using the Q&A feature within the Zoom dashboard, and then we will present them to Dr. Kaplan on your behalf. So Dr. Kaplan, we already have a few that have come in, and here's one that says, every patient is different, but how long do you anticipate rehab time for an incomplete quad would be, both inpatient and outpatient?
Well, I think you answered your own question in the very beginning. Everyone is different. So an incomplete depends upon the level of incomplete. Obviously, an incomplete quadriplegic patient with bowel and bladder issues is going to be much more complicated than an incomplete spinal cord injury patient who has paraplegia or an incomplete patient that has respiratory issues versus non-respiratory issues. So most of the patients that have a lower level injury with an incomplete may be anywhere from, say, 1 to 2 months. The higher, more involved incomplete injuries might be 3 to 4 months on an inpatient side. Usually the outpatient program is going to take anywhere from 3 months to a year. So it's a long process, especially if you want to get them completely back to work.
Yeah. Okay, thank you. Here's the next question that we have. What do you feel is the biggest stumbling block in rehab of a spinal cord injured patient? And when does this occur in the rehab plan?
I think the biggest stumbling block is delay in care and delay in start of rehab. So there are places around the country that someone has a spinal cord injury, they stay in the acute care hospital, they're in the ICU, they never get rehabilitation, they've developed complications. So by the time they get to a facility such as Gaylord, we're already working against a lot of problems that have developed. So I think there's two key areas. One, early on, that they need to be on the appropriate interventions from day one. And then later on, it's the delay in care, so that if someone is involved in a recovery program and doing well, but they're only getting authorized for, say, 8 visits at a time, they're doing well in therapy, then you're going to have a gap of a few weeks before we get approval again. That just causes a lot of ups and downs and really slows the whole recovery process. So I think on the front end, it's early interventions, and on the later end, on the outpatient side, it's interruptions in care.
Awesome. All right, I have one more question I think we can squeeze in. If you have questions, please submit them. You can use the Q&A function in your Zoom, or you can chat. I'm looking there as well. This one is, if the patient is capable, when do you start work hardening and then vocational services?
So it really depends on the type of job that they have. Some patients may not need a work hardening program. If they are returning to a sedentary job, we have spinal cord patients that can return to a sedentary job at a wheelchair level. If there's someone who wants to get back to a more physical level of job, we usually do work conditioning after they've had a single service physical therapy. If they've learned the exercises, they've done some general strengthening, but there's a gap in terms of where they need to be to return to their job. So say in the regular outpatient physical therapy program, they've gotten up to the point where they can lift about 10 pounds, they can stand for 5 or 10 minutes, but now they have to get back to a job where they have to lift 40 pounds, they have to be able to stay for a half hour. So that would be the point where we would transition them from single service physical therapy to more of a work conditioning program. We would add more of the work hardening aspect of it if we were concerned with the other aspects, psychological issues, nutritional issues, etc. I only do vocational counseling if the individual is going to switch their job. If they're going back to the same type of job or if their employer is willing to accommodate them, then there's no need for vocational interventions. If someone was, say, a construction worker or a police officer, and they have a complete injury or an incomplete injury that is unlikely to really gain much function, then I would do vocational assessment early on. Usually when they've transitioned from the inpatient to the outpatient arena, we usually don't do much vocational counseling when they're an inpatient because they're still trying to adjust to the injury itself. But we would do vocational counseling early on the outpatient side. So for example, if someone was a police officer and they've had a spinal cord injury, we want to try to get them back to work, but maybe it would be as a dispatcher, or doing forensic police work if they needed to get retrained, if they were, say, a detective. So that would be the point that we would do the vocational assessment relatively early on in their outpatient program.
I think this is a continuation of that work hardening question, which is what about traction?
Was there a specific question about traction?
There wasn't. I'm waiting for the attendee to, yeah, it says, what about traction? And I'm asking for more details. But for the sake of time, I thought I would just ask the question on their behalf.
Okay, traction, you have to be very careful. If there has been a more significant spinal cord injury, we try to avoid traction because we don't want to cause any more damage. Remember, you always want to do no harm. So you don't want to take something that is potentially an incomplete injury, say to level C or D, do traction and now cause them to go to a more complete injury or a higher level of an incomplete injury. So I usually avoid traction if someone has had a significant spinal cord injury. If they've had a disc herniation and it's really that they were trying to take some pressure off a disc, but the bony structure itself is stable and they don't have a true spinal cord injury, they just are having more issues with radicular pain, then we might do traction in physical therapy. But you have to be very, very careful with traction. And I will almost never do cervical traction. I'm very nervous about doing cervical traction. You can really do a lot of damage to the cervical spine if you don't do traction correctly. So in my practice, I tend to limit my traction to just lumbar traction where the risks are much less and the benefits are usually more.
All right, thank you. Well, for sake of time, we're not able to take any other questions, but I do want to thank everyone for joining our third session of the 2022 Injury Insight Series. Our next session and the final of the 2022 series is November 9th with Dr. Rohit Garg on brachial plexus and peripheral nerve injuries. Again, thank you, Dr. Kaplan. If you can go to the next slide, we do encourage participants to take the survey. It lets us know what you want to know, or it might be the slide before, Dr. Kaplan. Lets us know what you think of this presentation, what type of information you're looking for. We are partners in this work comp industry and want to make sure that we're supporting our adjusters and risk managers and claims managers. Again, thank you, thank you, thank you. Certificates of course completion will be emailed within 5 business days. And within 2 to 3 days, you'll have an on-demand playback available on our website. Again, thank you, Dr. Kaplan, and for everyone who participated. Have a great day.
Thank you.
Thank you.